ahead and get started. I'm Mike Bittner. I'm a Quality Improvement Advisor. I'll be joined by Tony Kentner, who's also a Quality Improvement Advisor. Today, we're giving a presentation on public health emergency preparedness and emerging infectious diseases.
So,
next slide, please. Go ahead.
So Mike, just before we get started, we do have just like a couple of announcements to make, and then we'll get going with the presentation. How does that sound?
Sure.
All right. So everyone knows I'm Kim Heft, and as you can see, I have Mike and Tony. They are fellow colleagues of mine in Superior Health, and they are going to be doing today's presentation on the emergency preparedness plan. I just want to give a little overview just in case you are new to this call. We host this session each week. We have a 30-minute educational session which highlights COVID-19. We talk about vaccinations and just other pertinent nursing home topics like today, right? Emergency preparedness. So after that, though, the second half of our hour is devoted to answering your questions and learning from your peers and discussing best practices. Now, before we get started, though, we are going to be doing a schedule change, and we would like your input on the frequency of this event. And the schedule change is going to either be, would you like every other Wednesday or every second and fourth Wednesday of the month? It will still be held at the same time. You probably just saw that a polling question has been dropped for you so that you can indicate what you feel would work best for you. So while that is happening, I also want to discuss a little bit more about the calendar because of the holidays coming up. So next week's session, which is 11/23, is going to be canceled. But after that, we're going to have sessions on 11:30 and on 12/7. But then there's still more because of the holidays. So look in chat. Kelsey's going to drop all of the dates that we have for the rest of the 2022 sessions and the very early 2023 calendar so that you have the most up-to-date information on when you should be joining us and when you should go and eat your lunch somewhere else, right? So,
and Kim, this is Kelsey. Just
yes.
One point of clarity. So we will be having a session next week. So next week's session is on the week after the week of Thanksgiving. That session is off, and that would be the 11/23. And as Kim mentioned, all of those details are in chat. The other thing to note is we did include this schedule in the presentation for next week. So if you don't capture this or write it all down, you will have this in the slide deck next week. So more to come. But again, Kim, thanks for giving an update on our scheduling here, because I know this is a little crazy with holidays.
Yeah, and thanks, Kelsey. Apparently, I think I want this Thanksgiving holiday to come quicker than what I was thinking. Yes, of course, we have a session next week. I do know that. Okay. So just like always, there's going to be a survey at the end of this session, so please fill it out. And Kelsey's going to put the link for this PowerPoint presentation into chat also in just a bit. Use that chat box. You're going to share your comments, questions, anything during the presentation, and we're going to use that for our Q&A session. So before we get started here, it looks like our polling question has come in, and we have 64% of you would like it on the second and fourth Wednesday, and 36 said every other week. So as soon as we get all of this information into a new schedule, we'll be sending that new invite out to you so that you know exactly when to show up. Okay, that was a big mouthful there. So with that, though, let's welcome Tony and Mike. Go ahead, Mike. Now I'll let you take that floor back.
Okay, sorry about that. So I've already done the introduction. We'll be talking about emerging infectious diseases. Next slide, please. Our objectives today, we're going to review key definitions and concepts related to emergency preparedness planning, things like mitigation, response, resiliency. We're going to describe the elements of Appendix Z related to emerging infectious disease, identify helpful public health emergency preparedness resources, and then we'll share some best practices and successes. That'll be more when we get into audience participation and stuff. Next.
Yeah, and I think this is where, this is Tony. So thanks for being here today. I think before we started, we kind of wanted to just ask a first poll question, just to kind of gauge your knowledge a little bit about Appendix C.
Okay. So the poll question should have popped up. To what extent do you think your emergency preparedness plan meets all of the elements of Appendix Z? If you're not sure, you can be not sure. Hopefully it's 100%, but just be on. I don't know why I'm answering it anyway.
So we'll just kind of wait a minute to see before Mike continues.
Have it,
kind of results we have.
Yep. And like I said, hopefully you're 100% confident. You feel like your plan hits all of the elements of Appendix Z. But if not, we do have some resources that'll hopefully help fill in some of the gaps that you might find in there. Okay, about half of you are not sure. That's fair. If this isn't something you work with every day, something you're not familiar with, there is probably someone else who has to deal with it in your organization. Hopefully they're at 100%. Then we've got a few 100%, 75%, which is still pretty good. Nobody's at 25%, which is great. That's a rough place for your emergency preparedness plan to be. We will go over some of the requirements for Appendix Z and what they are. So hopefully by the end of this, you're a little bit more familiar with it. Next. Nursing home reform in regards to emergency preparedness. CMS has started doing listening sessions. The emergency preparedness highlighted in the White House reform plan and in the report from the National Academies. They focus on proactive emergency preparedness. This is your all hazards approach as opposed to preparing for specific incidences within your scope of operation. According to the White House, CMS is examining and considering changes to emergency preparedness requirements and is working to bolster the resiliency of the healthcare sector as part of the administration-wide effort to be ready for the next pandemic and the next weather-related emergencies. Resiliency in this context is referring to the ability of an organization to bounce back from an incident, whether it's a fire, pandemic, or anything like that. Next. We'll go over some definitions of emerging infectious diseases and look at some examples. Next. What is an EID? There's outbreaks of previously unknown diseases, like what we saw with COVID-19, known diseases that are rapidly increasing in incidence or geographic range in the last 2 decades, so like a polio outbreak or anything like that. Persistence of infectious diseases that cannot be controlled, and this includes diseases such as HIV, SARS, cholera, Zika, West Nile, Ebola, dengue fever, all sorts of stuff. Next. Some of the key terms, definitions, and concepts. Go ahead. Appendix Z, which we'll be referencing a lot, it outlines the regulatory requirements for emergency preparedness. Emergent infectious disease was added in February of 2019 to the definition of all hazards approach in light of lessons learned from COVID-19. Which was just breaking out at that point and was rapidly added to Appendix Z. It identifies 17 facility types required to have an emergency preparedness plan. Organizations receiving funding from Medicare or Medicaid, and long-term care facilities are also included. Next. There are 4 provisions of the Emergency Preparedness Program. There's risk assessment and planning. That's when you evaluate what vulnerabilities your organization has. Policies and procedures. This covers what is required by Appendix Z. Your communication plan, how you are going to alert patients, how you're going to alert family members, how you're going to alert the general public, how you're going to receive information. That's all covered in the communication plan. And then there's training and testing, how you train new employees, how you train current employees, and then how you test those employees to make sure that they are aware of all of the regulations and understand during an incident what they're supposed to do, how they're going to find equipment, how they're going, if there's a shortcoming, how they're going to find more equipment from wherever you have your mutual aid agreements. These provisions must be in writing. You have to have a crosswalk to other documents, like an appendix or anything like that, so that you can get to your other operating procedures, and it has to be reviewed and updated annually. The comprehensive approach to meeting the health, safety, and security needs of the facility, staff, and their patient population and community prior to, during, and after an emergency or a disaster. A disaster is just an emergency, only bigger in this context. Next slide, please. The preparedness plan provides a framework for the program. What I really like about Appendix Z, you can tailor it to your specific organization. You can make it look like whatever you want, really. Appendix Z just tells you it has to have these things in it. How you make it work is entirely up to you. You can rely on best practices from your organization. You can look at how other people have chosen to organize this information. It's entirely up to you. It was developed based on facility and community-based risk assessments that assist a facility in anticipation and addressing facility, patient, staff, and community needs, and support continuity of business operations. Next slide, please. The all hazards approach. This includes natural and man-made disasters, facility-based emergencies, such as equipment failures, interruptions in essential services or resources like food or water, emerging infectious diseases, things like a pandemic, hazardous waste, bioterrorism, highly communicable diseases like Ebola or COVID-19. Next slide. Actually, could you go back one, please? Thank you. The all hazards approach, the goal here is because it is impossible to predict all of the different hazards that your organization is going to face. The whole point of the all hazards approach is you look at what your organization will have to do during as many disasters as possible. Like if there's a flood, a fire, essential resources breakdown, you'll need water, food, you'll need to be able to sustain that stuff for long periods of time. Doesn't matter what the hazard is, as long as you have that stuff, it's equal opportunity. You can use it for all of them. Next slide, please. So here are some of the components of Appendix Z. Appendix Z is fairly lengthy, but a lot of these will be covered in any emergency preparedness template. Next. Some of the provisions for emerging infectious diseases. For public health emergencies, such as pandemics, EIDs, there'll be a risk assessment that'll evaluate possible needs that include your hazard vulnerability assessment. A hazard vulnerability assessment looks at if we experience this type of hazard, if there's a fire, how vulnerable to that are we? And then it kind of ranks it by how likely that thing is. If you have a hazard that you are incredibly vulnerable to, that is also very, very likely, that is a hazard you're going to want to plan for. If you have a hazard that you're very vulnerable to, but is very, very unlikely, the example I always use for this is an active shooter incident. It's very, very unlikely the impact will be very, very high. Because the impact is so high, it's still something you have to consider, but the likelihood is still very, very low. You'll also look at the influx in need of personal protective equipment. PPE shortages were pretty rampant during the beginning of COVID-19. It's built into Appendix Z that you have to have where you will get more equipment from if you run out, how you're going to prepare your staff, things like that. Considerations for screening staff, visitors, and volunteers. How are you going to figure out who is showing symptoms, things like that. Transfers and discharges of residents, not just how you're going to receive people, but also when you let them go, how you track that, so you know where everybody is when you need to. And then you have your physical environment considerations, distancing, isolation. If you have single unit or single bed, or if you're running a single bed facility, isolation and distancing are a lot easier to do. If you have everybody, or if you have roommates, it's going to be more of a problem. Capacity surge, that's when you have a massive surge, massive influx of patients, and how you're going to deal with that. Next slide. Some more of the provisions address resident population. You have your types of services. The long-term care facility has the ability to provide in an emergency. Are you going to be able to continue providing those services during several different kinds of disasters? Mobility and transfers, again, tracking patients. Surge in staffing, if you're running with minimal staffing, how is that going to be impacted if people start getting sick, if people can't make it to work? Not just looking at a pandemic, but even something like a blizzard. How are you going to operate if like all of a sudden 5 people can't make it into work that day? Continuity of operations, how your business continues to operate. If one person can't make it into work, is there somebody else who can do all of the things that that one person can't do or can do? Delegations of authority, if somebody gets sick, if somebody can't make it into work, who has the authority to do whatever your organization needs to be done? And succession plans, if you lose somebody for the long term, for whatever reason, who takes over for that person? Who assumes their responsibilities? Who has their authority? Next slide, please. Evacuation, you need to develop and implement policies and procedures based on your emergency plan. Your evacuation plan is going to be very fluid and is going to depend largely on the type of incident or disaster. If it's something like a fire, you can stay within your community, evacuate at somewhere fairly close to home. If it's something more widespread, like massive flooding, hurricane, tornado, anything like that, you're going to have to look further and further out. It's hard to plan for that kind of thing, but that's where mutual aid agreements can be handy. The provisions for subsistence needs for staff and patients, whether they evacuate or shelter in place. These include, but aren't limited to, food, water, medical and pharmaceutical supplies. For food and water, you want to have your patients in mind. You also need to be aware of your staff. Alternative sources of energy to maintain your temperature for your facility between 71 and 81. Your emergency lighting, fire detection, extinguishing and alarm systems, your sewer and water disposal, any equipment that's necessary for your long-term care facilities, anything like that. Next slide. System to track the location of on-duty and sheltered patients in the facility care during an emergency. If you have a shelter-in-place incident, something like an anhydrous spill, or if there's a blizzard and you have to stay within the facility, you need to be able to track which of your employees you have on site, where your patients are, things like that. The specific name and location of the receiving facility or other location if an on-duty staff and shelter patient are relocated during an emergency. Even if it's something as simple as a spreadsheet, here's where we sent them, here's who received them, that's where, as far as we know, they are now. It's just so you can track your patients. Safe evacuation, this includes your care needs for evacuees. Evacuating certain facilities, especially long-term care facilities, is going to have its own set of difficulties and challenges. That's where mutual aid agreements with other hospitals, emergent or ambulance services, things like that are going to be necessary. Your staff responsibilities, make sure that your staff knows what they need to do during an evacuation. If they have specific roles or duties that they need to do they know that? Do they know how to perform those duties? That kind of thing. Transportation, if you have a mass evacuation, how are you going to get everyone from point A to point B? And then identification of evacuation locations, where you're going to send everybody, how you're going to get them there. Is a mutual aid agreement in place so that the receiving facility knows that in an incident, they have to take these people, that kind of thing. One of the issues that we ran into evacuating emergency homes during flooding in Fargo while I was with the Air National Guard, their plan was to evacuate everybody to all of the local hospitals in the area. The problem was, because it was a statewide incident, all of the local hospitals were already at full capacity. We had to start looking at South Dakota, Minnesota, like get people all over the place and then figure out how to transport them there. It's something difficult to plan for, but it's something you need to be aware of. Next slide. The use of volunteers during an incident. Volunteers can be really helpful. It's an extra pair of hands. You can get them to cover up some shortages, especially if you're short on personnel, things like that. However, there are a lot of extra concerns that come into play when you start using volunteers. Appendix Z addresses how volunteers will be used to reduce morbidity and mortality, minimize transmission, protect healthcare personnel, preserve healthcare system functioning. It is a useful tool. There are considerations that you need to take in place, like credentialing. If somebody shows up and just tells you that they're a nurse, you have to be able to prove that. You also probably should have volunteers performing real healthcare functions, unless there's something going really, really wrong. This element is usually overlooked in emergency preparedness plans. If somebody is using something like ICS or NIMS, those do cover the use of volunteers. Next slide. Waivers are covered by Appendix Z. This is a reference to policies and procedures that address the facility's role in emergencies, where the Secretary waives or modifies certain statutory or regulatory requirements. Currently, there's the 1135 waiver. Because everybody is actively responding to an incident right now, because COVID-19 is still an ongoing concern, the requirement for annual exercises is waived. You don't need to do an exercise. You are responding to an incident every single day. And you need a system in place to track the waivers and know if the waiver expires or goes away. Next slide. Your communication plan. This is a reference to a written communication plan that addresses how the facility coordinates care within the facility, across healthcare providers, or with state and local public health departments. When it says it has to be a written communication plan, again, this is where Appendix Z is very fluid, very adaptable. If you have a set of binders with all of this written down, that counts. If you have an electronic copy, that counts. There's a requirement to have a backup for your written communication plan. That can also take whatever form you need it to take. If you have one written and you have one electronic, then the electronic one is your backup. It works. Whatever works the best for your facility. Next. Occupancy needs and assistance. This is a reference to shortages of PPE, the need to evacuate or transfer patients, requests for assistance with transportation. That's where if you have a shortage, if there aren't enough ambulances to facilitate your request, where are you going to get more from? Temporary loss of part or all of your facility function. If there's a fire, if you're hit by a tornado, anything like that, how you're going to respond to it. Your staffing shortages, which I know is a very real concern in healthcare right now. The availability of electricity dependent medical and assistive equipment. If the power goes out and the power goes out for a long time, how are you going to respond to that? The method of sharing information from the EPP that is appropriate with residents, families, and representatives. You want your information flow to be consistent and reliable. However, you're going to tell families that their family members are fine. You want that to be an organized procedure. Next slide. Training and testing programs or drills are based on the facility's emergency plan. Appendix Z gives you multiple opportunities. You can do tabletop simulations. You can do full large-scale exercises that involve multiple stakeholders in your community. There are, and depending on your type of facility, it'll either be a 2-year requirement or a 1-year requirement. This includes staff and volunteer training, complementing the risk assessment. After you do your risk assessment, you want to look at the risks that you were deemed the most vulnerable to. Those will be the ones you want to run exercises for. Training should address situations identified in the risk assessment. Like I said, if something's completely unlikely, and even if it did happen, it wouldn't have that much of an impact, there isn't that much of a reason to run an exercise involving that. However, if you have a facility that's next to train tracks and you determine that anhydrous ammonia is used or is transported along those train tracks, an anhydrous spill is something that you would want to run a simulation for. The first time you respond to something like this, you don't want it to be when you're really responding to something like this. That's why training is important. And then you need to maintain your records of training. If you don't write it down, it didn't happen. You need to track when people attend these trainings or the training and figure out when they're new or when they're about to expire, when they need to do another training simulation. All new and current staff and volunteers should have training in emergency preparedness policies and procedures consistent with their roles. People need to know during an emergency or during a disaster what their role is going to be and how to perform those functions. Training at the time of orientation and annually thereafter, it works. The easiest way to do it is to get everyone on the same schedule. So even if somebody came on board 9 months ago, they're not due for another 3 months, but everybody does their training in February, have that person do their training in February. Demonstrate staff knowledge of emergency procedures. This is where testing comes in. People have done the exercises. Now you see what they have learned, evaluate how well they interpret that information. Next. Testing, you need to have 2 exercises per year. You need to participate in an annual full-scale exercise that is community-based. That is going to bring in your other stakeholders, police, fire, ambulance, other hospitals, things like that. Or when not accessible, conduct an annual facility-based functional exercise. This can be a tabletop simulation, a fire drill, things like that. A fire drill can be, it counts, but it has to be a part of a larger exercise. You don't need to do this if the facility experienced an actual disaster, which is nice, that counts as an exercise. Next slide, please. The goal of testing, you need to analyze the facility's response to and maintain documentation of all drills, tabletop exercises, and emergency events. Again, if you don't write it down, it doesn't count. Revise the emergency plan as needed. The best time to look at revising your plan is after an incident. The second best time is immediately after a large-scale exercise, or even a small-scale exercise. If you run the exercise and just a tabletop simulation, and you determine big gaps in your ability to function, that is a good time to bring that stuff up. It's when people are still thinking about it. We just had the exercise. We didn't do so well. We should fix this thing. Bringing it up in 6 months isn't going to be as effective. But again, the best time to bring this stuff up is after an incident. Everybody's still thinking about it. The what could we have done better is still fresh in everybody's mind. Consider adding emerging infectious diseases as a component of exercises. You'll be seeing a lot of this more after COVID-19, once exercises start becoming more and more prevalent. This is going to be a major part of how people continue to operate. You engage with your community partners, fire, ambulance, hospitals, in determining how best to provide effective services during a communicable disease outbreak. Your healthcare associations will be very useful at this, figuring out how you communicate with other organizations, things like that. Next. Recommendations and best practices to ensure a robust emergency preparedness plan. By robust, we mean it handles the most amount of, or covers the most amount of disasters or incidences. Next slide. Strong partnerships and collaborations, especially with your EMS public health department, your vendors, hospitals and other healthcare providers, fire department, and transportation services. This is where exercises are extremely essential. It's where you find out, I know that in the event of a disaster, I'm supposed to call the public health department. An exercise actually has you do that. And then you find out, like, we've had the wrong number, we've had the wrong email address. The person we were supposed to call hasn't worked there in 3 years, that kind of thing. Exercises will help identify those kind of shortcomings. Next slide. Teamwork. Teamwork, this is going to involve your subject matter experts, both internal and external, especially in a healthcare setting. With long-term patient care, you need to talk to the people in charge of long-term patient care, find out what their what their needs are, and figure out how you're going to address those needs. You involve the end users in the development of the plan. Again, talk to your doctors, talk to your nurses, talk to the facility staff, figure out how to get them involved with creating the plan and then implementing the plan. Critical information should be readily available and accessible to management and staff. However, you figure out a way that works best for your organization to communicate with everybody, test it, make sure that it works, and then stick with it. If it's a large text chain, that's fine. Teams, Discord, whatever you need to use. But make sure that you do test it, make sure that everybody is on board with it, everyone is familiar with it, and that you have a way of accessing it if you lose power or infrastructure. Assess and update alert and response procedures. Your plans should be specific. Your staff should know and understand their roles. Again, they should be trained when they first come on board, and then there should be annual training after that. And then how you're going to handle communication and notifications. How are you going to let family members know that they can't come visit? How are you going to let staff know that you are experiencing shortages and they might need to be called in? Things like that. Next slide. Quality improvement. You want to look at the response to COVID-19 or other emergency situations. There are other disasters that are still going on right now, other incidences, small scale, large scale. There's a lot of different things you can look at. You want to look at what worked well after a disaster. What did your organization do well? How did you handle the incident? There's always good lessons learned. What opportunities are there for improvement? What would you do different if you had it to do over again? Things like that. Determine the causes of any difficulties or barriers. What caused the problems that you ran into during a disaster? A disaster is always going to have difficulties. It's a disaster. Things aren't going well. That's the definition. How could it have gone better? What the parts that you control, how could you have smoothed them out so that you can get more control over the situation? Incorporate those best practices strategies into your emergency preparedness plan. Again, the best time to do this is immediately after an incident. Use your root cause analysis to identify any breakdowns in the emergency preparedness response. If communication got away from you, how come? If you found out that a lot of your stakeholders or community partners didn't have ways of contacting you, why did that happen? And then once you've identified those causes, fix them. Integrate emergency preparedness into quality assurance and performance improvement. Make sure this is a regular part of your testing. Review and audit emergency preparedness program and plan on a regular basis. Again, the best time to do a review is immediately after an incident, but make sure that somebody looks at this at least once a year. Somebody checks the communication plan. Do we have a bunch of phone numbers on here that are no longer valid? Do a bunch of these people no longer work here? It's time. That's when you want to update all of that. Next slide. Training, you want to look at your staff and volunteers, make sure that their training is consistent with their roles. Are they receiving per diem? What agency are they working with? Things like that. Check with your policies and procedures. Make sure your orientation covers training and then that you review it annually. Staff training in psychological safety and first aid to support residents. And then make sure you write down when the plan has been updated. Again, if you don't write it down, it didn't happen. Ensure staff can demonstrate knowledge of emergency procedures. Do they know what they're going to do during the event of a disaster? Do they know what their role is going to be? Do they know who they have to talk to, who they have to contact, things like that. Next. Testing, you want to partner with local agencies and organizations. A lot of large-scale exercises involve outside stakeholders. You're going to want to make sure that you have ways of communicating with them. You want to ensure your schedule of testing is completed timely, twice a year, once a year, or if you're under a waiver currently. You want to review and analyze data to make improvements. Look at what went well, look at what went wrong, improve the things that could have gone better, and then focus on how to continue doing the things that went well. Maintain documentation of drills, tabletop exercises, and emergency events, and revise the plan when needed. At least review it annually. Next slide. The emergency preparedness review. Tony, did you want to take this one?
Sure. So as a service to the nursing homes in the 3 states that we serve, Michigan, Wisconsin, and Minnesota, we are offering to review all of the nursing homes' public health emergency preparedness plans to help you ensure that your plan meets all of the requirements of under Appendix Z. We've reviewed about 350 plans to date. We've created a very nice checklist tool that relates directly each element. It relates or correlates to the element in Appendix Z, and it references many of the items that Mike has already described here. Once you send us your plan, we review that plan for you. We provide some comments and some feedback. There's some resources that are associated with that, the review or that document that we send you back. And you're able to use that, if we're unable to locate something. What I've had a lot of facilities do is they're kind of using this again as a quality improvement approach. And they're ensuring that that documentation is somewhere in the facility and that it's current and up to date and meets the requirements of Appendix Z, so they can take credit for that as part of their QAPI program. So we're happy to review your public health emergency preparedness plan. There's the email address that you can send it to, or you can certainly send it to Mike or myself, and we can make sure that it gets to the right folks to get that reviewed and taken care of. And so far, we've gotten some nice feedback from the nursing homes about the value of us helping to do that. And it just kind of helps relieve or helps just them feel more comfortable that their plan is addressing all of the elements that it needs to. And if we're identifying a gap, then that gives an opportunity, like Mike said, to kind of make sure that that material or that information is present. And if it isn't, then address that so that your plan remains as current as possible. So we're happy to review those. I think next slide. So before we get to the resources, we had another polling question. Kelsey, do you want to bring that up for us? So yeah, what's your biggest challenge with emergency preparedness planning? So we're just kind of curious to sort of hear from you about the elements that we've just discussed and which one might be the one that keeps you up at night, or it seems it's the biggest challenge to you, or you struggle to make sure that the element is met. So while we're waiting for people to fill that out, if you want to go to the next slide, Kim. So we've just compiled some resources for you that might be helpful to you. The first one obviously is the link to Appendix Z. It is fairly lengthy. It's broken out, though, I have to say, really well as it relates to the requirements for nursing homes. So once you kind of get the hang of how to look at it, it works pretty well. And then we've also included some other training through the QSEP education portal. There's some training. There's a couple of elements. One is kind of a shorter a shorter training that you can do, like it's maybe an hour, hour and a half, and the other has like there's a number of trainings and it takes a bit longer for you to go through that. And then we also included these other resources as well. And is there another slide, Kim? I can't remember. Yes. And so just some additional, Mike had, we talked about the nursing home incident command system, that the materials from the California Association for Healthcare Facilities, that's a really nice document. It really kind of helps sort of frame the network of an incident command system as it relates to a nursing home. And then of course, we've got some other items for you as well. So let's see, Kelsey, have the results come in yet?
They have. Do you want me to share them?
Sure, that would be great.
You should see it on your screen.
Yeah, okay, so training looks like it's kind of the biggest challenge. Half of the group said that. And then a quarter were the all hazards approach, and then 13% evacuation, and then a smaller 13% other. So it'd be interesting maybe if people could chat in what the other relates to. That would be great. And then before we kind of get to some questions from the audience or comments, I just want to say, since I started learning more about emergency preparedness and Appendix Z, I think what struck me is that even when you think you have things really under control, for example, I'll just take the communication plan, and you have think you have a good plan, and then you have a backup. Just kind of think outside the box about what happens if there's like a total failure of like all communication systems, or like the towers go down, so you can't communicate with each other via cell phone. So really kind of challenging yourself to think about, well, we've identified these, this is our what we're going to use as our main communication plan, and we have this backup, but what happens if the backup fails? So really kind of starting to look at that. Same as with transportation. You might have agreements with transportation companies or other organizations, but what happened? Do they have other contracts with other organizations, other nursing homes? And so if something happens in your community, like everybody's going to need their support, and they might not be able to handle that volume. So how are you kind of thinking again, sort of to look at maybe some other kind of sort of maybe less traditional, or some organizations that you maybe haven't thought of in your community that might be able to help you. So so I think I've really learned that you sort of have to have a plan A, a plan B, and maybe a plan C. All right, so are there any questions that folks in the audience have, or any comments?
And feel free, if you do, to unmute your lines or your phones and speak verbally. Otherwise, the chat box is always open for feedback.
Well, so it sounds like training was an issue that a lot of you have. So I'm just wondering if some of you can share what you're doing at your facilities to make sure that your staff understand their role in emergency preparedness. And are you doing any competencies related to emergency preparedness? Can anyone speak to that to help others out?
So Christy, while they're thinking about that, I'm glad you brought that up, because Mike, when you did your presentation, you indicated that there was a requirement for staff training in psychological needs during, whatever the event that's happening. And I'm like, whoa, okay, how are we doing that? That was like my first, and do you have any suggestions, or maybe that's in the training already, that in the resources?
So Appendix Z, it was specifically referring to isolating your patients and how to handle the difficulties that come out of that. It does list different resources that you can use, and then some of the stuff that we provided as well, we'll talk about it too. But there is a bunch of different training that you can use for this. Almost all of it is free or open source. You just have to find it.
And I know, just taking COVID as an example, you know, that certainly had a huge impact from a psychological safety perspective on both the residents and the staff in the you know, facilities. And you know, there's been, I think, a lot of work done about, you know, building resilience and you know, like trauma-informed care as it kind of relates to those experiences that we have, like COVID, that have gone on for a long time and are very traumatic. So like SAMHSA, for example, and some of the other of those organizations have a lot of resources on resilience, helping build resilience, helping overcome that. I know, just speaking, I had to evacuate a residence a long time ago, and I wish I had known what I know now, but I didn't. But I can tell you that one of the things that I did for my residents after we evacuated and the staff is we had just some kind of informal meetings, and they went on for a while and on an ongoing basis, and just sort of let people talk about their experiences and acknowledge what they were feeling, and you know, try to make them feel you know, safe and that they were supported, and that we, you know, we wanted to hear from them so we could best support them. That seemed to really really help a lot. And then of course for my staff, we had the employee assistance program, so we made sure that people also, you know, were aware of that and could, you know, certainly use those resources, as well as other local counseling services that we kind of connected them with.
I have a quick question for everyone that I feel like everyone should have an answer for. So at the start of the pandemic, so think back to February, March of 2020, where did you feel like your emergency preparedness plan back then had the biggest gaps? What were things that you just were not prepared for? And then what were ways that you got creative? When Tony was talking about thinking of plans A, B, and C, it kind of made me think of that worst case scenario, which I think plenty of people ended up getting themselves into because there were so many issues with getting PPE and things like that, and having staffing shortages. So what were the things back then that you felt like you were the least prepared for? And kind of what have you done since then to get creative, to make sure that you're prepared in the future if something like that were to ever happen again?
Please feel free to unmute yourself, because as you're typing away in chat, it might be a little difficult for such a lengthy answer to a question, possibly.
Yeah, I see Rita, major staffing issues, and there's still a problem. Absolutely. I think that's probably something across the board. Has anyone found a creative solution? It's the $1 million question probably there. What is that solution to that? How about, Mike mentioned those community-wide trainings. How many of you, since the pandemic, do you think that you have partnerships in your community now that you could try to do some of those more large-scale testings that Mike mentioned? Or were you doing them before? Like, does your community already set up to have those more wide-scale emergency testings? Do you think that things like that would be helpful for you to do rather than kind of testing them out on paper? Any thoughts on that area?
I will say the training and testing will also be impacted by the staffing issue. It is very difficult to try to, like, how are we going to run an exercise when you're already running at max capacity and nobody feels like doing extra work? And this stuff is all, it's costly in time and resources. It takes a lot of effort. So staffing is still going to impact this.
Mike, once the 1135 waiver has elapsed and it's no longer pertinent anymore, and then there is the yearly requirement for the twice a yearly requirement, right? For
It depends on your facility, but it's either once a year or twice a year.
Okay, will that
Or
be
on your type of facility, sorry.
okay? Well, whatever the facility would be, and like for now, for example, this is our long-term care SNF population. Would that requirement be by like whatever that end date of the when the waiver expired, and then you have a year from them to get your 1 or 2 in or whatever it is?
Correct. You'll have the 365 from when it ends. Because you were in a disaster up until that point. So that actually counts as your exercise. You were responding to an incident. So once that ends, then you've got a year to get compliant again.
Thank you.
Yep.
I know there were a lot of people that said that they didn't know, they were unsure in that first question. Were you just unsure of the name, that Appendix Z? Were you more sure of what was talked about today? Did some things get cleared up now that you've sat through this? Talk to us a little bit about that for those that were unsure. We feeling better now? That was a pretty big group. It was 50%.
Yeah. And while people are pausing to think about that too, as I mentioned previously, if it would be helpful for us and alleviate some of your, unsuredness, to have us review the plan, we're happy to do that and best support you in whatever way we can.
I just wanted to add Mike and Tony's email and phone numbers so that just to follow up, yes, get those plans reviewed by these two very well-known people in this area of emergency preparedness. They really know how to check your plan out and will definitely be able to give you some tips to make sure that you get it running effectively.
And just as an aside, we're kind of in the beginnings of working on a sort of a series that kind of delves into some other kind of issues related to emergency preparedness, like how do you address health disparities in your emergency preparedness plan? A little bit more about the resilience piece. Hopefully after the first of the year, if things go well, we'll be able to have kind of more of a series that kind of delves into some other issues related to emergency preparedness that I think you might find really helpful as well.
Well, any other questions from our participants? How about from the Superior Health staff? Do you have anything else you'd like to add in regards to this conversation? Well, I really enjoyed this conversation and the information that Mike and Tony brought here today. Please fill out the evaluation that is being dropped or had been dropped already into the chat. The slides are there too. There again is a meeting next week. Do not listen to me. I don't know what I'm talking about apparently. So yes, next week we do have a meeting, and we're going to have a question and answer open forum in regards to NHSN. Everything you want to know and more, please be prepared to come on in and ask your questions, but we'll already have some questions and answers formatted just in case you forgot to ask something. So with that being said, that concludes our session for today. Everyone have a great afternoon, and we will see you next week.